Good afternoon, everyone. Thank you for coming for this important international conference on stigma. My name is Minabi Ford. I'm the Executive Director of the Mignon Innes Ford Foundation. We are a small community-based African-centered organization. We work in cultural bridge building, cultural orientation for African newcomers. Among the major challenges, as we have spoken earlier, is African health. In the area of African health, the representation is poor in terms of awareness. I really want to thank Dr. Jackson and Dr. Rana for including this component of Latino and African community. A lot of times when we talk about stigma, we from the African community, even to some extent from the Latino community, we feel a little bit lost because stigma for us has a total different language. It's culturally impacted and faith-based element in it. As a result, most African people in the community are not able to articulate the impact of stigma in their community. They are highly, highly negatively impacted by stigma. In addition to coming to the country and getting adjusted to all sorts of things, they are highly impacted with the HIV, as you can imagine. I'm very, very grateful and excited to have this opportunity to hear the African perspective. Also, there's a confusion a lot of times when we talk to policymakers or funders. They do not know the distinction between African Americans and African immigrants. It seemed like it's too much trouble for some folks to say, well, you're Africans, period. No. Even within the African community, it's a continent, and each region comes with a different stigmatized challenges that has to be culturally tailored to address this impact. I'm very, very honored and proud to have two ladies who have been really doing foundational work to establish, really to prototype, to show how culturally and linguistically we can start working with the African immigrant community. I'm not going to go on too much because they're going to give you an incredibly thorough discussion and information about that aspect. The first speaker that I would like to invite is Ms. Margaret Korto. She works nationally and internationally, both with the government and non-governmental organizations, providing training on a number of health issues, facilitating conference, developing strategies, organizational planning. She's with the Office of Minority Health. She manages the National African Immigrant Project and works with several organizations around the U.S. who have African clients with HIV. She also partners with several agencies to provide culturally appropriate to African community in the U.S. Ms. Korto.
Thank you all for being here and staying with us. I'm not going to take a lot of time to talk about this because I have my colleague who is going to go into the work that we've been doing, because we've talked about stigma and that's all we talked about all day. But how do we change that? How do we get the communities to start looking at themselves, knowing that what they're doing, what they're saying is stigmatizing whoever they're talking to? Or how do we get the people themselves to stop self-stigmatizing? And as my colleague before me said, Africa comprises of 56 countries. Out of these 56 countries, each country has over 20 tribes. Each tribe has over 20 dialects. So you could just imagine trying to work with Africans. And that's why I say just because somebody comes from Africa doesn't make them culturally appropriate to work with an African. And that's something that you have to always remember when you're working with Africans. I do a lot of presentations. I tend not to go with slides. If you want copies, you can get it. The information is there, but since I have it here, Africans tell stories, so I'm going to flow with it that way. Okay. All right. So Africans tell stories. They stigmatize each other. They come from different countries, and I'm from Ghana. We can have 20 Ghanaians in this room, and none of us will be speaking the same dialect. And then people coming from Africa also, your status is very, very important in Africa. And all those things really are bridges to whether or not this person is going to work with when you identify an African as somebody that they should work with. So what have we done? As we all know, the government does not set aside funding to work specifically with African immigrants or for Afro-Caribbeans. We are all put under African Americans. And that does not work because our cultures are so different. And so what the Office of Minority has done is, in this, the US, we have Africans who are immigrants, and then we have refugees, and we have asylees. And those three are very different groups. Mostly the immigrants are the ones who came here to go to school, overstayed their stay, came to visit somebody, stayed longer, and they're usually more educated and speak very good English. And if they happen to stay long enough to get their green card or start working, earn good money. And so you hear a lot of Africans say, well, the African community is one of the most educated, and it's usually the immigrant community. And then we have the refugee community. That doesn't make them less educated, but these are people who have been taken out of their home country, sometimes without it wasn't a choice that they made to come here. And so when you get here, getting through all the hardship that you have to get through before you establish yourself makes it harder for the refugee community, harder for them than for the immigrant community. Because the immigrant community, most of the time, is a choice you made to come to the US. And then there's some of us who, maybe you're a diplomat's child who came here, you were in school, your parents left, you were left behind, you're supposed to come, you got married, you had children, you stayed here. So there's so many different groups within the African group. And so it depends on who you're working with. What you might say to a refugee that would be okay, if you said the same thing to an immigrant, might feel like an insult. What you might say to an immigrant that would be okay, you see to a refugee, they might say, you don't understand my situation. So it's a huge thing to work with. So what my office has done is we started working with organizations that work with Africans. First, we started targeting African-led organizations because even the business acumen for an African is very different than the African-American or the American community. The way we do businesses back home are not the way business is done here. So one of the things that we do is build leadership for African organizations, help them understand how do you work within the American system, how do you navigate the system, and then help them work with the community that they've chosen to work with. And you'll be surprised when it comes to HIV, a Nigerian would rather go to a Ghanaian doctor because we go to funerals and parties every weekend, and I might write into you. So I'd rather go to a Ghanaian who goes to Ghanaian events that I don't go to. So sometimes you think, oh, because I'm from Nigeria, I have somebody in my office is Nigerian, this person who is sick is a Nigerian, so let me introduce them. That could be the worst thing that you were doing, even though you had the right idea. Because, like I said, ask any African here, every weekend there's a funeral or a party, and the chances are we're going to meet there. So those are some of the things that we help the community look at. And one of the things that the office did was we have commissioned African providers and PhDs who have done research in stigma within the African community. And we've written an anti-stigma curriculum. And this curriculum is two-pronged. One, like the doctor who spoke when the first panel was speaking, addresses non-African healthcare workers on what are some of the nuances that you get when you work with Africans. For instance, one of the very common ones is when a physician is in this country, when a physician is talking to you, they want you to be part of the care they're giving you. Whereas if somebody grew up in Africa, the doctor knows best. You go to the doctor, you tell them what's wrong, they tell you what to do. So how do you then make sure that your client comes to the table so that you can work in unison to help them with the issues that they have? So we have the training to do that, but we can't just put the onus on the providers. How about the community itself? So we have a community piece that talks about when the doctor asks you questions, he's not just trying to dig into your business. There's a reason why he needs to know or she needs to know these things so they can help you do what you need to do. So Dr. IJ is going to be coming on to tell you a little bit about trainings that we've been doing around the country. We've been working with health departments who actually, we help them look at their needs assessment form and revise it. Because when you ask an African, how did you get HIV? Was it anal sex, vaginal sex? Right there, you shut the door. We don't have sex, we just have babies. So when you start talking about sex and you're bringing these things, because there's no word for anal sex in the African language. So even you have an interpreter, they have to describe this act to the person you're talking to. And sometimes they choose not to, so they tell them what it is they feel comfortable telling them, because also age is very, very important. So if I'm 50 and you bring somebody who could be my child to describe anal sex to me, they're not going to do it. And then we look at the Muslim, a huge piece of the African communities are Muslims. And so you look at that part and how, when it comes to sex, how you're dealing with that. So we have the professors who go out and do the trainings. And one of the things that we also realized was that, can I have my water? My mouth is so dry. My water, please. Is that one of the things that we realized was happening a lot was, thank you, was how the African community navigates the healthcare system itself. And I'm talking about going through the hospital. And those of you who work here, you realize that most of Africans come to the hospital through the emergency room. And I've heard a lot of people say, oh, a lot of them don't have insurance. That's not true. A lot of Africans have insurance, especially the immigrants that have the good jobs, they do have the insurance. But we did not grow up with wellness care. We grew up with sick care. If I'm well and I can go to work and I have a headache or I have a boil growing on my body, I have to do everything else that I know how to do. And if that fails, if I can't get up and I have to crawl to open my door, that's when the doctor is needed. It doesn't matter whether or not I have insurance. I see my brother here nodding his head. And I have a husband who, we've been here for over 30 years, who does the same thing. And he would say, I don't need to go to the doctor, they'll just charge me. And I said, well, we have insurance. And he would say, when I'm sick enough, I'll go. And you hear us say this a lot. And it's not because we don't know how to go to the doctor. It's just, this is the way Africans were brought up. Therefore, as a physician, if an African comes to you and you're saying, why did you wait till this late to come? They'll be just looking at you like, what are you talking about? And I tell people, when I was growing up, there was a hospital in Ghana. It was a teaching hospital, but anybody who went there died. And it's called Kolebu Teaching Hospital. And I thought it was the worst hospital. But now I understand that by the time they got there was nothing the physicians can do. And so we are educating the community that you need to yes, even though you're not sick, each year go and have yourself checked. And so these are the things that the trainees are doing with the people. And we have partnered with Adventist Healthcare System. And what Adventist is doing trainings for its physicians and the community around Adventist. And we're looking at intake, from intake in the hospital to discharge. Because people think that when an African is discharged and they give you a list of things to do, if it's married, unless the wife is there, that's not going to get done. And so there are certain things that the clinicians need to know so that they can treat the patient the way they need to be treated, because 9 out of 10 times, you will see that patient consistently. Why? They got the instructions, but they don't do anything about it. And sometimes it's not the family that you need there, it's the best friend that you need there because of the relationship they might or might not have with the family. And when you're talking about HIV, the family probably doesn't know they're infected. So there's a lot of issues that we need to look at. And so we got some money from the Minority AIDS Initiative. It wasn't a lot of money, but we, as minorities, we know how to use a little money. So we've been doing trainings around the country and brought Adventists in. And Dr. IJ has been one of my consultants who's been doing the training, so she will be the one talking to you about exactly what it is. I'll have some cards if you need to talk to me, if you need us to come into your organization to help you set up a culturally appropriate way to work with your clients, or if you need the training for the clients, we're also willing to do that. And it's all for free. Thank you.